I'm going to show you the visual outcomes that we have with our new inverted meniscus IOL. So this is arterioles, and it's the first inverted meniscus EDOF IOL. This is a real picture of an IOL implanted in the eye, and you can see that um, its inverted meniscus is concave and convex surfaces instead of the traditional biconvex IOL. So this new concept mimics the properties of the crystalline lens, speaking about periphery. So we optimize the field of curvature. With the standard biconvex IOL, you usually have the central vision optimized, but you have worse peripheral vision. While with this particular shape, we optimize both the central and the peripheral retina. This idea of inverted meniscus came from a study that was done like 10 years ago by Barjeken, and they use a Harman sac that can measure up to 40 degrees of retina eccentricity. They did a study in patients that have in one eye their natural crystalline lens, and in the fellow eye a biconvex IOL, a standard monofocal one, and they found out that the patient have less peripheral defocus and less peripheral astigmatism in the eye with the natural crystalline lens compared to the eye with the IOL. So with this in mind, the idea of having this meniscus shape to optimize both central retina, peripheral retina came. So apart from that particular shape, they are standard IOLs, sorry. They are non-diffractive EDOF. We have aspheric surfaces. Both of the surfaces are aspheric. We have hydrophobic material, and all the characteristics are standard. So we have three different models. All the models are based on EDOF technology. We have R25, that is the model with less negative spherical aberration. R40, that is the model with a medium amount of spherical, negative spherical aberration. And R70, that is the model with more negative spherical aberration. So we use negative spherical aberration to increase the depth of focus. Now I'm going to present the results or our combination of R40 in one eye and R70 in the fellow eye. Why we do that in that way is because you know that when you increase the depth of focus, you increase near vision and you can lose a little bit of far vision. So just to be sure that the patient have excellent vision at all distances, we implant one R40 in one eye and the fellow eye with R70. So when you see this defocus curve, the results are excellent at the three distances, and they are comparable to trifocal IOL. However, as they are EDOF and we don't have any diffractive profile, we don't have any dysphotopsias. We also ask the patient about the quality of vision questionnaire and also about the patient-reported spectacle independence. The patient never experienced none of the visual system like glare, halos, or Starbucks. Regarding the spectacle independence, we found a high spectacle independence for the three distances. It's a little bit less at near, but when we ask about the comfort without glasses, all time or most of the time, the percentage are higher. So the patient can be most of the time without any kind of correction. So maybe they can need a glasses for near if they are reading a long time, but if not, they can do their daily life with any kind of correction. We also measure the contrast sensitivity both best corrected and uncorrected, and the results were similar to monofocal IOLs. As I said before, this inverted meniscus optimized the peripheral optics, so we wanted to replicate the experiment that I showed you before, and we measured the refraction up to 40 degrees of eccentricity with two groups, one with ART-IOL, R25 model, and the control group was with a standard biconvex monofocal IOL. You will see that the central part of the retina is similar for both defocus and astigmatism, but as we move to the periphery, there is a huge difference in defocus and in astigmatism. We found out 2 diopters of defocus and 1 diopter of astigmatism when you compare to biconvex IOL. Although this study was done with R25, the results are similar for all our models because this is due to the inverted meniscus. And just for you to remind, this is the previous study that I showed you before. So in blue, we have ART-IOLs in the top plot and no IOL, like natural lens, in the below plots, and you will see that the results are pretty similar. So we mimic the optic that you have when your natural crystalline lens. So just to conclude, we have that RTOs provide better peripheral visual quality. RTOs present comparable trifocal visual acuity as trifocal refractive IOLs without any associated dysphotoxia when we speak with this combination of R14 in one eye and R17 in the fellow eye. Also, this combination achieves spectacle independencies for all daily activities and viewing distances. We have very good tolerance to refractive error, and we don't present a reduction in the contrast sensitivity. Also, with this inverted meniscus design, we don't induce any negative photic phenomena associated to this IOL.